Welcome to this video on arterial blood gas, or ABG Procedure and Interpretation. I am Dr. Sayed Rizwan Mehdi, an emergency physician at Care Hospital Mushirbad. An ABG is a diagnostic test that measures three core physiological components: oxygenation, ventilation, and acid-base status. It uses arterial blood, typically sampled from the radial artery. The most common site for sampling is the radial artery. Essential equipment includes a heparinized syringe. The procedure starts with the Allen's test, followed by needle insertion at a 30 to 45 degree angle. Pressure must be applied for 5 to 10 minutes post-sampling. Proper heparinization prevents clotting. Excess heparin, however, can dilute the sample, falsely lowering PaCO₂ and pH. Air bubbles in the sample lead to gas exchange with room air, causing falsely high PaO₂ and pH values. ABG is indicated in respiratory distress, metabolic disorders like DKA, and for critical monitoring. Key symptoms suggesting the need for an ABG include signs of respiratory failure or altered mental status due to hypoxia or severe acid-base imbalance. Common risks of the procedure include hematoma, which can be prevented by applying firm pressure. Arterial spasm and the risk of thrombosis or embolism must be minimized with proper technique. The normal pH range is 7.35 to 7.45. PaCO₂ should be 35 to 45 millimeters of mercury, and bicarbonate, HCO₃, 22 to 26 MEQL. Normal oxygenation values include PaO₂ of 80 to 100 millimeters of mercury and SaO₂ of 95 to 100%. ABG interpretation uses the Rome method. Step 1 is checking the pH. Step 2 uses Rome to identify the primary disorder. Respiratory values move in the opposite direction of pH, while metabolic values move in the equal direction. We have covered the basics of ABG analysis. Next, we will delve into a detailed examination of the individual components and their physiological effects on ABG results. ABG assessment parameters fall into three categories. Oxygenation is assessed by PaO₂, AA gradient, and hemoglobin. Ventilation is assessed by PaCO₂. Acid-base status is assessed by pH, HCO₃, and base excess. For accurate interpretation, we must note the patient's SpO₂ and FiO₂. SaO₂ from the ABG must correlate with the monitor saturation. PaO₂ values help assess lung injury severity, with values below 70 to 100 millimeters of mercury suggesting hypoxemia. The PF ratio, PaO₂ divided by FiO₂, assesses oxygen transfer. It's a critical measure for classifying ARDS severity based on the Berlin criteria. A ratio below 200 suggests moderate ARDS. It's important to translate oxygen flow rates into FiO₂ values. The rule of thumb is that each 1 liter per minute of oxygen increases FiO₂ by approximately 4%, starting from 21% room air. The AA gradient measures the efficiency of oxygen transfer from the alveoli to the arteries. It is calculated as alveolar oxygen pressure minus arterial oxygen pressure. A normal gradient ranges from 5 to 15 millimeters of mercury. Alveolar oxygen pressure, or PaO₂, is calculated using the alveolar gas equation. TH is a critical step for determining the AA gradient and assessing gas exchange efficiency in the lungs. The first step in calculating inspiratory oxygen pressure, or phosphorus dihypoiodite, involves the formula. Phosphorus dihypoiodite equals FiO₂ multiplied by the difference between atmospheric pressure and water vapor pressure. At sea level, this is approximately 285 millimeters of mercury for a patient on 5 L per minute nasal cannula. The AA gradient reference is calculated as age divided by 4 plus 4. A normal gradient suggests correct oxygen transfer, while an elevated gradient points to an intrinsic pulmonary issue, such as VQ mismatch or shunts. The 100% oxygen test differentiates a VQ mismatch from a shunt. Significant improvement in PaO₂ indicates a VQ mismatch, where alveoli are accessible. Minimal improvement suggests a shunt, where blood bypasses ventilated alveoli completely. Alveolar gas relationships show that increasing PaCO₂ decreases PaO₂ and PaO₂. Reduced atmospheric pressure at high altitudes also lowers oxygen levels. The ABG machine directly measures pH, PaO₂, and PCO₂. Hypoxemia is insufficient oxygen in the blood, while hypoxia is inadequate oxygen in the tissues. Total oxygen content, or calcium oxide, sums the oxygen bound to hemoglobin and dissolved in plasma. A clinical target PaO₂ of 75 to 80 millimeters of mercury corresponds to about 94% saturation. This image illustrates the relationship between PF ratio and the A-way gradient, further emphasizing how these values help assess pulmonary gas exchange efficiency. PaCO₂ is normally 35 to 45 millimeters of mercury. Respiratory acidosis occurs when excess carbon dioxide forms carbonic acid, decreasing the pH. The relationship between PaO₂ and PCO₂ is essential for understanding oxygenation. pH measures the fluid's acidity or alkalinity. Normal blood pH is 7.35 to 7.45. Acidosis, the process attempting to lower pH, can lead to acidemia, the state where blood pH is successfully dropped. Acidosis is the process that tends to lower the blood pH, while acidemia is the resulting state of a low blood pH. The Henderson equation shows the reversible reaction that balances carbon dioxide and bicarbonate in the blood. The Henderson-Hasselbalch equation mathematically defines the acid-base relationship. In the bicarbonate buffer system, pH equals 6.1 plus the log of the ratio of bicarbonate to PCO₂. The interpretation of ABG follows a four-step logic. Check the pH for acidosis or alkalosis. Identify the normal range for the key players PCO₂ and hydrogen carbonate. Determine the cause, and evaluate the compensatory response. Metabolic acidosis with low bicarbonate triggers respiratory compensation via hyperventilation to lower PCO₂. Metabolic alkalosis with high bicarbonate leads to hypoventilation to retain carbon dioxide. Respiratory disorders use renal compensation, retaining or excreting bicarbonate as needed. Actual bicarbonate is directly measured and influenced by both systems. Standard bicarbonate is a calculated value, isolating the pure metabolic component by assuming normal PCO₂. This distinction helps pinpoint the true metabolic contribution. Bicarbonate correction is indicated for severe metabolic acidosis, typically if the pH is below 7.1. The deficit is calculated using body weight, actual, and desired bicarbonate levels. Only half of the calculated dose is given initially, followed by reassessment. A standard ampoule of sodium bicarbonate contains 25 MEq in 25 milliliters of an 8.4% solution, providing a concentration of 1 MEq per milliliter. Always verify concentration before administration to ensure accurate dosing. Base excess is the magnitude and direction of the metabolic contribution to the acid-base disturbance. The normal range is -2 to +2 mmol per liter. A positive base excess, above +2, indicates metabolic alkalosis or compensation for respiratory acidosis. A negative base excess or deficit, below -2, indicates metabolic acidosis or compensation for respiratory alkalosis. Actual base excess is measured in the patient's blood, reflecting whole blood buffering capacity. Standard base excess is a calculated value representing the extracellular fluid, providing a more accurate reflection of the total body metabolic status. The anion gap is the difference between measured cations and anions, calculated as the sum of sodium and potassium minus the sum of chloride and bicarbonate. The normal range is 6 to 16 mmol per liter. A high anion gap, or HAGMA, suggests the presence of unmeasured acids, often remembered by the mnemonic mud piles. A normal anion gap, or NAGMA, occurs with simple bicarbonate loss, such as in diarrhea.